All right, we are live. I know we're switching it up. We're kind of flying by the seat of our pants today with this one. We tried to film a YouTube video. Apparently, I don't have enough space on my iPad to keep doing that, so I need to delete some of the videos that we've done in the past. So what we're going to talk about today is leg length inequality. It's a question that we get a lot in the office, so we're just going to kind of address it. So hopefully our patients, any students, any other doctors out there watching kind of know what it means to us. Is it clinically significant? What is clinically significant? So I'll just kind of frame it to Corey. If a new patient comes in and says, hey, I have a short leg, which they seem to always announce, that's right, something that they say. How do you typically respond to that?
So if it's a new patient, I would say this is kind of twofold. If it's a new patient, I would say we'll go through our examination. We'll see at the end of that exam if it's clinically relevant. And that's the biggest question for me is this leg length inequality or discrepancy going to change the way I treat them? Typically it does not. And if I get that question from a patient that's a current patient that's been established, then my answer is that most people have leg length inequalities. Like it's something it's more common than not. We could grab 100 people off the street right now and do a leg length check, and 90% of them would not have the same leg lengths because we're asymmetrical. We're adaptive machines, and that's kind of what we do is we adapt to changes. And the way we adapt to changes is by increasing muscle tone. And muscle tone can change the way the pelvis aligns and the way the hamstrings are tight in one side, and it can change things. So Jace asked me a question right before we did this, is how many heel lifts, because that's typically the treatment for a leg length inequality, is to put one of these little heel lift things in there to help kind of level out the pelvis and take stress off of the low back through a heel lift. I've probably put 6 or maybe 8 in a 13-year career. So not many. I don't use heel lifts as a main part of my treatment. Again, he's got a good study there that we both have looked at, and clinically, leg length inequalities aren't relevant to change treatment until they get to be like 20 millimeters, which is like 3/4 of an inch. So that's pretty significant. So the question is the leg length inequality functional? Because if it's functional, we're not really going to do anything to change that through a heel lift or any sort of change in the shoe wear. That's going to be changed by how we treat, which we don't need to put anything in the shoe if we're going to treat the functional cause of the leg length inequality. Or is it a leg length inequality due to like trauma or some sort of like degenerative change in the hip or hip dysplasia, broken legs, hip replacements, things like that? Those are typically when we put a heel lift or some sort of supported device into the shoe that will change, kind of how you walk and help us with our treatment.
Yeah, so I think the big divide there is going to be anatomical versus functional. So Corey kind of alluded to earlier when we were talking is like if we checked your leg length and then we had you go run a mile and then you came back and we checked it again, it's likely going to be changed. And the reason is not the anatomical portion of it, because your anatomy isn't changing, it's the functional causes. So let's say you go run a mile, you have faulty diaphragmatic breathing, you tend to over-recruit quadratus lumborum, a muscle over here that's a square shape, or erector spinae, the ones in the back, kind of the ropes. Then that's going to hike that hip and then make that leg short, quote unquote. So functionally, yeah, we'll treat that. We will teach you how to breathe and we will teach you how to relax this. And this study found that people that's had a functionally short leg, they tested the endurance of the quadratus lumborum and the erector spinae on that side, and they were more easily fatigued than the other side, hence why it tightens and then shortens. So that's why they have a short leg functionally on that side. So that's typically what I do. If somebody says that, I'll just go, which we do anyways in our assessment, is I'll just go start hunting around the muscles around the pelvis and kind of monitoring tone side to side. And that's something that we use later on in assessment to go back and retest, like, right, is this muscle able to stay relaxed after activity? Can you breathe in your diaphragm so this muscle doesn't have to overwork and carry too much tension within it?
Right. And that's what we look for. We look for functional changes, and most of the time the leg length inequalities will be addressed with the change in the function or the way we make things adapt. The other thing that can cause a functional leg length inequality is an aggravated or an inflamed joint in the low back area, because that also recruits those muscles. Our brain just increases the tone of those muscles that can unlevel the pelvis. And so even joint restrictions, because those two muscles and joints, they talk back and forth to each other, and any change in that communication will change the recruitment of the muscles. So you'll recruit a whole different group of muscles that you shouldn't, which can change leg length inequality. The other thing from a clinical standpoint is if you have tibial deformities, like a tibia varum tibial torsion, which is bowing or twisting of the tibia, that's usually caused by some sort of developmental thing that goes on in the hip. That's usually addressed by a full foot orthotic. So we would make a custom orthotic for that and not worry about the heel lift, because that'll be addressed in the orthotic. So there are some criteria that we use for orthotics here, and that would address those leg length inequalities versus just putting in a heel lift. If you're a practitioner or a manual therapist, this is a must-have book. It's called Human Locomotion by Tom Mashad. He goes through all of the different ways that you can test for leg length inequalities and whether it's clinically relevant or not. He's got some cool, real quick, easy tests that you can do that we use here to tell us whether we need a heel lift. But that's a good reference for you manual therapists, physicians, chiropractors out there, that if you do have questions about that, he's kind of got that all laid out for you, and he doesn't miss much.
Right, so kind of the take-home points. Is it anatomical or is it functional? Functional, you're coming in here, we're evaluating you, we'll kind of tell you, is this clinically significant, but also use kind of those pelvic muscles, the muscles up here, to kind of monitor progress with treatment, and as well as just kind of our typical assessment, the joint and motion palpation and all that. So those are kind of the big take-home points. Corey's put in 6 to 8 heel lifts in his whole 13-year career. I am 1 year in practice. I did not put in a heel lift, so I guess I'm probably on a similar pace.
Right.
So I think that kind of concludes this episode. We will be back on next week. Hopefully get this a little bit more consistent. Whether it's going to be on YouTube or Facebook Live, you'll just have to wait and find out.
And we don't know either. So
I'll clean up the iPad, get some of these videos off. We've had a fair amount of videos, so check out our YouTube channel, because they're coming off my iPad and they're staying up on YouTube. So thanks a lot.
Have a great weekend.